muscle for the thumb and the little finger. So you can see on this model here, and then you can look at your own hand, you can see that there's a mound of muscle created along the first metacarpal, and another mound of muscle along the fifth metacarpal that kind of come together at the base of your hand. And so these are known as the thenar and hypothenar eminences. So along the thumb, we have the thenar eminence, which is that mound you see right here and right here, around the ventral view. And on the little finger side, we have the hypothenar eminence. And these are made up of 3 muscles for each group. All right, we're going to learn one from each of those. But for the hypothenar eminence, we have the abductor digiti minimi, flexor digiti minimi, and opponens digiti minimi. So those are the 3 muscles that make up the hypothenar eminence. We're just going to learn to identify the first one. For the thenar eminence, remember what our word for thumb is? Pollicis or pollux for single. So here it's going to be abductor pollicis, but we already have an abductor pollicis, right? The one that wrapped over the high wrist area. That was abductor pollicis longus. So this is going to be abductor pollicis brevis. And then there is a flexor pollicis. Do we have a flexor pollicis already? Yes. Flexor pollicis longus was the deep muscle in the anterior forearm. So this is going to be flexor pollicis brevis. And then we also have an opponens pollicis. So the opponens pollices are what you would use to do this movement. All right. The abductor pollicis brevis and abductor digiti minimi, however, are the only ones that I'm going to have you be able to identify on the model. And so these muscles, and you'll notice there's no origin and insertion that you have to know. I just want you to be able to identify them. The function is what the name says. So abductor digiti minimi is going to come on the outside here of the fifth metacarpal, and abductor pollicis brevis is on the outside of the first metacarpal, and it abducts the little finger and it abducts the thumb. Okay. So on your hand models, it's going to be the most lateral or the most medial on the surface of the hand in this fashion like this. All right. So, yeah. So on the outside, the abductor digiti minimi, and on the outside, abductor pollicis brevis. Okay? But I just want you to know what the thenar and hypothenar eminences are. Now you'll notice, when I turn off the light here, you can see a nerve, a yellow nerve going into the thenar eminence. That's a branch of the median nerve. Those are the only muscles in the hand that are innervated by the median nerve, are this group of 3. So this is all going to be median nerve. All the other muscles in the hand are innervated by the ulnar nerve. In fact, you've probably seen, you may have in your own home, the old-fashioned kind of faucets made out of porcelain that have the X shape to them. And if you were to try to tighten that or undo it, they could break. And so it wasn't uncommon to have them slice into the base of the thumb right here, cut that median nerve, and then those individuals would lose the function of abductor pollicis, flexor pollicis, and opponens pollicis. Now, opponens pollicis, that's the only one we have. All right. However, we do have the abductor pollicis longus and flexor pollicis longus. So it would be the opponent's movement, bringing the thumb over to touch the little finger like this, that would be lost if they were to cut that median nerve. Median nerve, however, is sensory to the rest of the hand, except for the fourth finger, all right? So median nerve is only motor to these muscles of the thenar eminence, but sensory to the rest of the hand. Ulnar is motor to all the rest of the hand. And I'll give you a particular function that is a good test for damage to the ulnar nerve. Now, all the muscles of the hand are found in the palm. There are no muscles that are part of the dorsal surface of the hand. We can see muscles in the dorsal surface. Oh, did you want it?
There it is.
Or torn? Okay. Okay. All right. Yeah. All right. So this is the dorsal surface. So you can see there's a muscle here that you can see between each of the metacarpals. You can see that muscle. It's not found, even though we can see it through the dorsal surface, it's still considered to be a muscle of the palm of the hand. All right? So let's look at this view here. And I'm going to draw it in the reverse. So these muscles are the dorsal interossei that we're going to talk about next. Interossei meaning between the bones. All right? So their origin is off of the metacarpal, and their insertion is onto the proximal phalanx. But look at the pattern in which they insert. So let's find the midline of the finger is the third metacarpal, the third finger, all right? So this is considered to be the midline of the finger. You'll notice for the dorsal interossei that we have a tendon that attaches here and here. So we can take the third finger and abduct it this way or abduct it that way, okay? Away from the midline. Remember, abduction is away from the midline. So if the third finger is the midline, then this is abduction and that is abduction. All right, because we're pulling it away from the midline. And then to move this one away from the midline, where would our tendon have to attach? On this side or on this side? On this side. So that would move it away from the midline. And this one to move it away from the midline.
Right side.
Okay. And so we have then, this one is out here as well. All right. So we have this first muscle here, forming this tendon. This right here does this. That's the dorsal interosseous. Okay. Here's the other dorsal interosseous. We have 4 dorsal interossei. Abducting, abducting, abducting. So if you look at the back of the model, if you happen to have one, you look at this location right here between the thumb and the second finger. All right, so it's going to look like right here on the back of the hand. This is palm, but look on the back of the hand. So you're looking here. That, what fills in that web space is the first dorsal interosseous.
Okay.
Okay. Now when you turn it over and look on the inside of the palm, it looks very similar. It looks almost identical. That's a different muscle. Okay, that's going to be called the adductor pollicis. So to find dorsal interosseous, you need to look on the dorsal surface of the hand. And that's a dorsal interosseous muscle. Dorsal interosseous. There are 4, and their function is to abduct. So think of this acronym. DAB. Dorsal interossei, abduct. Okay, they take away from the midline. So they're going to be doing this. So the second finger does this, the third finger does this, and this finger does this. Okay? So we have 4 muscles to move 3 fingers. Remember, we don't need it for the little finger. That has its own abductor digiti minimi. We don't need it for the thumb. That has its own abductor pollicis brevis and longus. So we have 4 abductor muscles. One pulls the second finger away from the midline. One pulls the fourth finger away from the midline. The other 2 move the third finger to either side. Does that make sense? Okay, so dorsal abductor. Now, we have palmar interossei. And there are only 3. Let me turn the lights off so you can see those better. Notice the midline, the third finger, doesn't have any tendons. Okay? So the second, the fourth, and the fifth finger have tendons for adduction. So I'm going to draw those tendons in green. And they're going to be on the medial surface. Okay? So we're going to have, you can see right here, we're going to have them on the second, the fourth, and the fifth finger. We're going to have an adductor tendon here, an adductor tendon here, and an adductor tendon here. So they're going to move the second finger towards the third, the fourth finger towards the third, and the fifth finger towards the third for adduction. Okay? So those are known as palmar interossei. So we have 3 palmar interossei. And they do adduction. Have. And remember, it's in reference to the third finger. I'm not giving you the finger. It's in reference to the third finger, which is the midline of the hand. So we did not need an abductor. We didn't need a dorsal interosseous for the thumb, because we had abductor pollicis, longus, and brevis. We don't need an abductor for the little finger because we have abductor digiti minimi. Remember, those are the 2 muscles we found out here and out here. All right? But notice that there is no pad, there's no palmar interosseous for the thumb. So how do we adduct the thumb? That's the muscle that you can see on the palmar view of the hand. And that's this muscle right here. So this is the palmar view. And I'm not going to draw another hand on the board, so I'll just show you this diagram. So here, abductor pollicis has been cut. Abductor pollicis brevis has been cut. Abductor digiti minimi has been cut. Here are the palmar interossei. And notice this fills in the web space between the thumb and the first finger. This is adductor pollicis. So on the back of the hand, it's the first dorsal interosseous. On the palm of the hand in the same location, it's the adductor pollicis. Okay? This is innervated by what nerve? Ulnar. That's right, because only the 3 thenar muscles are innervated by the median. Everything else in the hand, including adductor pollicis, is ulnar nerve. It's the only muscle to the thumb that's innervated by the, bless you, it's the only muscle to the thumb that's innervated by the ulnar nerve. Yes?
In the picture, is the one underneath the other 2?
Well, it's, let me draw it on my hand for you. It's not water soluble, but it's on the palm of my hand, so I can handle it. That muscle is dorsal interosseous on the back of my hand. Okay? That muscle on the palm of my hand is adductor pollicis.
Is the abductor pollicis not ready to go over it?
Abductor pollicis is here on the side of my thumb.
Okay.
That's abductor pollicis.
And
Brevis.
then the flexor?
And then flexor would be on the inside right here, slightly over adductor.
Slightly over.
Yeah. Okay, but abductor pollicis fibers are very horizontal.
Okay.
On the board, right next to the palmar interossei, on the black, portion, yes, what is that?
This is going to be the one I showed you right here, dorsal interosseous.
No, I'm sorry, the
Dorsal.
black.
This one?
Dorsal atrium.
The black is the tendon for dorsal interosseous.
Oh,
Makes sense now.
Okay, so the black is the tendon for dorsal interosseous. The green, I'm not showing you palmar interosseous because it's going to be behind the board, but that's the tendon for palmar interosseous. And I'm not showing you the actual muscle. If we go back to this image, so here's the dorsal interosseous. That's the tendons that are in black are these white ones here. So they're on the this is abductor digiti minimi here, so don't worry about that one. But this one is dorsal interosseous on the little finger side, dorsal interosseous, dorsal interosseous, dorsal interosseous. Okay? 4 dorsal interossei muscles starting between the first and second metacarpals. Then the palmar interossei are only 3. And notice their tendons go to the opposite side. We're bringing them in rather than pulling them out. Okay? So there's 4 dorsal. So these black lines here are for the red muscles that I drew, the dorsal interossei. And I did not draw in the 3 palmar interossei. I can do that, but it's going to be on the wrong side. I don't know if it's going to help or not. But this would be dorsal interossei, palmar interossei like this. So it's pulling those bones towards the 3rd finger. Just move the fingers, okay? What causes this finger to pull out this way is a muscle that attaches here, dorsal interosseous. So I'll do it on, get another pin. So based on this hand here, all right, so here would be dorsal interosseous is going to pull this hand this way. Does that make sense? It's going to pull this finger this way. This dorsal interosseous, down in here, attaches to that right there. It's going to pull this finger in this direction. The 3rd interosseous is going to pull that same finger in the opposite direction. And the 4th interosseous is going to pull my 4th finger that direction. So I have 4 dorsal interossei. Then if I switch the palm of my hand and I turn it around so that I'm looking at it this way, all right, this is going to be a palmar interosseous bringing this finger in this direction. Here's a palmar interosseous bringing this finger this direction, and another palmar interosseous bringing that finger that direction. So the 3rd finger has 2 dorsal but no palmar because it's called abduction when it moves both directions. Now, before we move on to the lumbricals, remember I said all the muscles but the ones, the thenar eminence, are innervated by the ulnar nerve. So the best test, let's say you fell off of your bike or you were rollerblading, skateboarding, whatever, and you crashed on your elbow and they want to check and see if you damaged your ulnar nerve. The best test, rather than to have you flex your fingers or flex your wrist, because median nerve does a lot of that stuff too, all right, the best thing is to give the person a piece of paper and have them grasp it between their fingers. So you're going to be doing dorsal interossei to do this, palmar interossei to do that, and only the ulnar nerve provides that function. So that's the best test for damage to ulnar nerve. Okay. And then the last muscles we have are called the lumbricals, and those are, lumbrical means worm-like. And the lumbricals are these muscles right here. There's 4 of them along each of the digits 2, 3, 4, and 5. This tendon is the tendon of flexor digitorum profundus. So the origin of this muscle is from the tendon of flexor digitorum profundus, and it inserts onto what's called a fascial hood, an extensor hood. So it's kind of like a piece of connective tissue that wraps over the knuckle, this joint right here, this IP joint. But it starts on this side. So what it does is it pulls this muscle down and then straightens this joint out. So it flexes the MP joint, and then when it pulls on it, it straightens the finger joint. So it's going to do this, it's going to flex the MP and straighten that finger out like that. So it flexes MP and extends the IP. So it kind of pulls from underneath on that kind of hood and straightens it out.
Some people can do the
Yeah, the very tip you're using the flexor digitorum profundus. But this is how we can extend, extend that part with the flexor side. Even if you don't have radial nerve to extend your fingers, you can still extend that part with the lumbricals. And those are also ulnar nerve. Okay? So you don't have to know origins and insertions for those. Except for lumbricals, the name of what the function of the muscle is in its name. Dab, pad, adductor pollicis.
The lumbricals, it's median and ulnar.
Well, the first two are median, but we're not going to worry about that distinction. The second and third are median. All right, now let's look at the abdominal wall. Okay? Most of you are familiar with the rectus abdominis and the obliques. So let's look at those. They're really a continuation of the muscles that we learned about that are the intercostals. And if you recall that, remember the intercostal nerves passed between, they were the ventral rami of T2 through T12, and they passed between the internal and external intercostal muscles. Well, our muscles of the obliques are ilioinguinal and iliohypogastric, right here. They're part of T12 and the first lumbar, and they also pass between the internal and external intercostals. Okay? So, yeah, I'm going to erase the board unless you have any take pictures of that. Okay, I've been putting on the world.
We're going to sushi today.
Origin is going to be
Yeah.
the tendon of
Good
flexor
idea.
digitorum profundus.
What's up,
And
Chica?
insertion is the
Trying
extensor
to
hood.
get
It's
stuffed
called
on some sushi or what?
extensor hood over each of the IP joints.
Stop it, I was just thinking that.
Wait, so yes or no?
Apparently, yes. I was just thinking it.
Everybody down? Not down.
Digitorum, digitorum, argument.
High five.
Just figure it out.
Props, man.
Maybe. Joe, I'll send you a picture.
And? Gotta commit. Good. Joe, did you bring your pills?
He has to tutor.
Oh.
I told him I'd send him a picture. I did last time, Trish and I went.
I tutor anyway.
He told me something dirty.
Dirt? Ew. Joe? Really? No. What'd you send him a picture of?
Last time I went to sushi.
Uh,
You should have taken a picture of your cupcakes. You're gonna have fun listening to this.
what?
On YouTube.
No.
Right?
You guys know my face has access. She'll take an AFB.
That little show that you just did right now.
You know what's gonna happen at 2 in the morning when I'm looking at this YouTube video? I'm gonna see that and like be like, just remind me.
It's
All right.
gonna be like one of
That would
those
be
scary things,
fantastic.
you know, those look really, really close. And then the
The
exorcist
muscles of the anterior abdominal wall function primarily to compress the abdomen, so when you're trying to hold your tummy flat. All right, we're going to be using the obliques and the rectus abdominis. These obliques, as I said, are a continuation of the intercostals. So the external intercostals form the V pattern, and the internal intercostals form the upside down, the mountain pattern. Same with the external obliques. The external obliques form a V, the internal obliques form upside down V. All right? So I'm going to, there's a band of connective tissue. I drew it over here, but this time I think I'll draw it here. So let's look at how this fascia, because in addition to attachment to the bones, we have a plane of fascia, the linea alba and linea semilunaris, which contribute to the attachment of these muscles. So here's a cross section looking at the abdominal wall as if I were to cut it through right here and then looking at the edge of it. Okay? So these two muscles here would be the rectus abdominis muscles. And then we would have the external intercostals. On the midline, we would have the internal intercostals. And I'll draw them on the anterior view as well. And then on the inside of that, we would have the,
I have a question.
yes,
I'm sorry to interrupt. It's very hard for me to hear you. Can I turn this off?
sure. All right, so external, internal, and then what are called the transverse abdominis that go horizontal. So now let's look at the band of connective tissue. This would be fascia, the epimysium that covers our muscles. All right. So on the transverse abdominis, the epimysium that covers the transverse abdominis muscle joins on the inside and goes behind the rectus abdominis. So it forms this tendon that then travels behind the rectus abdominis. The external oblique, its epimysium comes together and goes in front of the rectus abdominis, like that. And then the internal one splits, and the outside goes above and the inside goes like this. All right, so we have these areas here and here. This is known as the linea alba, or white line. And these two are known as the linea semilunaris, kind of a curve. And so that's what we're seeing in this view right here. So here would be the linea semilunaris, and right in the midline, the linea alba. So here's what I drew on the board. Here's the two rectus abdominis muscles that run down the midline of the body. The fascia for external oblique goes on top of rectus abdominis. Fascia for the transverse abdominis goes on the inside, and the internal oblique splits and goes around both. So that creates linea alba, and then that would be right down the middle here, and then linea semilunaris. So here's linea alba, and here's linea semilunaris on both sides. Okay? So not only does the muscle have attachment to the pelvis and to the ribs, but to this midline where there is no bone that helps to support that. So transverse abdominis, we're not really covering. It's fibers that go horizontal. So let's put the internal oblique up. Remember, for the internal intercostals, they pulled the ribs down. The origin was inferior to insertion. So for this case, our origin is going to be from the iliac crest into the semilunaris and into the lower ribs. Okay, so that's internal oblique. external oblique. It's going to have the same attachments, but in the opposite direction. So origin is going to be the lower ribs. Inserts into the linea semilunaris and to the pelvic bone. So we'll draw that over here. And comes around from the outside as well. So if we're just looking at both of the internal intercostals, okay, we would just see the V line. So on this side, this is external intercostal. On this side, it's going up, it's internal intercostal. So if I had both my patterns here like that, that would be the upside down V. If I had both my patterns like that, that would be the regular V. So external intercostal, internal intercostal. Okay? Now let's look at the rectus abdominis. That's going to be two bands of muscle. Rectus means straight. So there's two sets of muscles that are forming these packets. And there are bands of connective tissue in between each one. People talk about a 6-pack. Typically it's an 8-pack.
We have more work to do, Keaton.
All right. So we pull our little umbilicus there. So this muscle would be the rectus abdominis. This would be the linea semilunaris on each side. This would be the linea alba. Okay. And then in between each of these packets is known as the tendinous insertion. So my mom came out to stay with us for about 3 months after my twins were born, because they were born on a Friday at noontime, and I was back teaching on Monday. I didn't realize I was adjunct at the time, and about 50% at the med school. I didn't realize we don't have maternity leave here, even if you're full-time. Maternity leave is not part of our benefits package. We've been trying for 2 years to get pregnant, so there's no way to plan the due date. I was teaching here. I was teaching at Sac State. I was teaching at Casumnas at night, and I was teaching at the med school. So my mother came out. The babies were brought on Friday. We brought Will home, Savannah home on Saturday, Will home on Wednesday, and my mom showed up in between there. So she started harping on me about starting to exercise. She's about 125 pounds overweight. So I'm like, Mom, you have no room to talk. I didn't say that to her, but I was thinking the same thing. You know, I'm too busy to exercise. And she said, lay down on the floor. She said, put your hands right here, just above your belly button, and try to do a sit-up. So I literally could put my fingers under the edge of each rectus abdominis about 1.5 inches. Kind of like this, on each side. And I was like, okay, fine, I'll start doing sit-ups. Just because of the stretching of the abdominal wall. So these muscles all together do compression of the abdominal cavity. If you're trying to cough, or if you're trying to blow air into a balloon that's resistant, you're going to use those muscles to compress the abdominal cavity and push the diaphragm up. The lateral muscles, the obliques, also do what we call lateral flexion. Okay? So doing it this direction, doing this direction is lateral flexion. If you were to lie on the floor, wrap your arms around your shoulders and then kind of slide one down to your waist and then lift this shoulder off the ground, you could really feel the muscles tighten up there in that space between your ribs and your iliac crest. And those are the oblique muscles. All right? Okay, if you want a picture, I'm going to move on to the levator ani. Yes?
Could you label the side of the X
Oh, external oblique, sure.
And it's what is it? Tenuous? It just looks like
Green
a
muscle.
lunar.
Space.
It's not on. It's not on here. I mean, it's on it, but it's not like. Park was Are you awake over there, Ghost Rider?
I am.
All right, so the
You want my hat?
next segment is the muscles that form the pelvic floor. And the muscle that you see up here on the screen is this muscle right here, called the levator ani. It fits into the floor of the true pelvis in this fashion. There are actually three different muscles that form the levator ani. It forms kind of like a bowl at the bottom of the pelvis. Okay? And you're looking at it from this view. Here's looking at it from, this is from the inside, and here's from the outside. Okay? So that would be from this view, and this one is from this view. All right? So let me see which one we'll look at it from this one. So this is from somebody that's laying on their back with their legs up in the air. Here would be the pubic symphysis and the ischial tuberosity. That wide of pelvic angle, that's got to be a female. Right? So we've got the sacrum and coccyx here, and we'll put the rectal opening here. Okay? So the three muscles that make up the levator ani, two start from the pubic bone, and the first one forms a sling around the rectum. So it goes pubis to rectum to pubis. Part of that forms a thickening, that is the external anal sphincter, but the rest of it forms this sling, so that is puborectalis. Right. Puborectalis. Then we have pubococcygeus. So here's our coccyx. So pubococcygeus is going to come off of the pubic bone and attach to the coccyx. So that's pubococcygeus. That would be this one here. Okay. And then the next one is iliococcygeus. And iliococcygeus actually comes off of a muscle that covers the obturator foramen. So this is going to be iliococcygeus here, and it's a more lateral. So that is iliococcygeus. And it forms the floor of the pelvis. again, you're looking at it from this view. So here would be puborectalis. Here would be pubococcygeus coming all the way down to the coccyx. And coming from the lateral aspect is iliococcygeus. Okay? And again, if I put it in place, it's like that. Okay? So it forms the floor of the pelvis. This is the muscle, one of the major muscles, the other one is the external urethral sphincter, that is involved in Kegel exercises. So if you're a woman, you've probably heard about Kegel exercises. You can figure out which muscle to tighten up. It's this one and the external urethral sphincter. So stand in this one right here, and I'll diagram that in just a moment. We'll take this one, and the external urethral sphincter is a horizontal muscle that lies inferior to levator ani and fills in this triangle and also forms a sphincter around the urethra. So if I were to diagram that muscle, again, make this one a male, you guys don't feel left out. The urethra would be here and the vagina would be here. So in the male, this is now would be something that we would set in front of that because it's deeper. So these fibers are go horizontal. And fill in that space there. Identified as, well, it has three names. External, urethral sphincter, deep, transverse, perineal muscle or perinei, and urogenital diaphragm. That's the actual muscle name. The others kind of just describe where it is or what it does. So for both these muscles, if you stand in a shower, all right, or someplace private, and let a stream of urine start, and then stop it by squeezing muscles in the floor of your pelvis, you would be squeezing this external urethral sphincter, but you'd also be squeezing the levator ani. All right? And so that just is to get you the feeling of the muscles that you use, because you don't want to do that all the time. It could cause the urine to back up into the ureter from the kidney. That's just to help you know what it feels like. And then you can do that exercise anytime, you know, during the day or in the car or whatever. I had a student about 10 years ago, she was telling me, she said, about her sister, whose husband had offered her a birthday present and had offered to give her either a vaginoplasty or a breast enhancement. I'm not sure who the present was for, the woman or the man, but anyway. Vaginoplasty is where they surgically tighten up the vagina. After childbirth, the muscles get stretched out, all right? And so the student told me, she says, I'll never need a vaginoplasty because I do 500 Kegel exercises a day. Jesus. I was like, you know what, every time I see you now, I'm going to think, she's doing Kegel exercises right now. And so, especially in women who have had children, all right, that stretches the ligaments that support the uterus and the bladder to the abdominal wall, the pelvic wall. And after menopause, with low estrogen, that weakens those ligaments even more. And the bladder can kind of pouch downward into and out the vagina. So if you have the vaginal opening, here's the urethra and bladder, okay? Here's the vagina and uterus. So what can happen, here's the abdominal wall. What can happen is either the uterus, here's the cervix, the whole thing can settle down. So what you see is the uterus like this, an inch or two from the opening of the vagina, or it can actually come out the vagina. Or you can see a combination of that, but you can see, because it pushes on the bladder, you can have the bladder doing this and coming out the vaginal wall opening. Okay? So you may have heard advertisements for a vaginal mesh. So what that does is it pushes the bladder up and puts a artificial tissue between the vagina and the urethra, or between the vagina and the rectum, to attach that to. Or they can do surgery either intraperitoneal or behind the peritoneum or within it to attach the bladder to the wall of the uterus, or they can just take out the uterus. Okay, so a hysterectomy. And this is sometimes what causes women to leak urine when they cough or run or something like that. So there's a variety of